believe you just built him up.
He's been in a meeting on that.
John was picking up on with him. We were going to do. He's got it.
Okay, let's begin. Let me have your attention. Welcome to the University of Tennessee Nuclear Engineering Department Colloquium Program. My name is Lee Dodds, and I will introduce today's speaker, but before I introduce today's speaker, I need to make a couple of comments. This is our last colloquium of this fall semester. Next week is the annual meeting of the American Nuclear Society, and most of our faculty will be at that meeting, and so I did not schedule a colloquium for next week. And the following Wednesday is the Wednesday before Thanksgiving, and we know from past experience that that is not a good day to have a colloquium. People like to leave early for their holiday weekend. And the following Wednesday after that is study day, and the semester is over except for final exam. And so we will begin our colloquium program next semester. The first colloquium will be the first day of class, which is January the 12th. Okay, now for today's speaker, we don't have enough chairs today. It's amazing. The speaker is Dr. Donald Blaufox, who is the chairman of the Department of Nuclear Medicine at Albert Einstein College of Medicine in New York City. We just had lunch with Dr. Blaufox, and he's a very interesting person. Let me give you some of his background. He went to Harvard and did not get his degree. Back then, well, at least not the first time, you could go to Harvard for 3 years and then enter medical school, and they take 2 or 3 top students each year without a bachelor's degree. And so he got into medical school at the State University of New York in Brooklyn. After getting his MD, he joined the Mayo Clinic, and he was there for 4 years. While he was there, he was in their PhD program, which is jointly with the University of Minnesota. And his first college degree then was a PhD in medicine. He already had an MD in medicine. Come in, have a seat. And while he was there, he developed an interest in nuclear medicine and the use of radiation and radioisotopes. He went back to Harvard on a fellowship and pursued that interest, and then he joined the Albert Einstein College of Medicine in 1966, specializing in kidney disease and nuclear medicine. He eventually became, first it was a division of radiology, and then it became its own department. He became the chairman of nuclear medicine in 1983, a position that he still holds today. Having had lunch with him, he has some very interesting extracurricular activities which I want to share with you. He collects antique medical instruments, and he's written 2 books on the use of these instruments and the history of medicine. He's also an avid collector of electric model trains, and I like that too. I do a little bit of that, not very much. But what got my attention is that he collects wine, and he told me just a few moments ago that the purpose for collecting wine is to drink it. Okay, and I think most of the students here could probably identify with that. And so, in other words, he's a very interesting person. The title of his presentation today is Introduction to Positron Emission Tomography. And after having lunch and learning about all these other interesting activities, I encouraged him, if he wanted to change his topic, he could do it. But I think he's probably still going to talk about PET. So without any further delay, ladies and gentlemen, please welcome Dr. Donald Blaufox.
This is a bit of a first for me. I'm used to speaking either to medical audiences or lay audiences, and you guys all fall somewhere in the middle. So it gave me a challenge in how to organize the talk. And of course, I have to first point out that PET Doesn't mean you should bring your cat or your dog to us, which does happen from time to time. We've had people come into the facility, which is labeled the Einstein Pet Facility, asking us where they bring their stray animals. We take care of only human beings. I've divided my remarks into two parts. I'm going to go through some of the basic physics, engineering-related principles of PET, which I think might be of interest to all of you from a vocational point of view, where the challenges lie. And then I'll say a little bit about the physiologic and medical aspects of the procedure. Wait a minute.
Takes an engineer.
Yeah, okay. Okay, let's start off with a definition. PET imaging is a molecular diagnostic imaging modality that detects and characterizes the biologic basis of disease. So it's different from what you're used to in traditional radiology. Imaging modalities are based, like CT, MRI, ultrasound, are based on physical characteristics, on changes in anatomy such as density. What we do is image the function of the body, taking advantage of some specific tracer that allows us to see a particular organ. Among the diseases that we are involved in today are lung cancer, lymphoma, melanoma, GI cancers, head and neck, sarcoma. We also look at gynecologic tumor recurrence, that's ovarian, uterine tumor, cervical tumors, renal tumors, and endocrine tumors. This is in the realm of oncology. The major application of positron tomography today is in imaging patients with cancer, where it's very effective in defining the extent and the spread of the disease and complementing the other anatomic modalities. Prostate cancer and bronchoalveolar cancer are also specialized forms where the procedure is a little less valuable. But throughout the range, if you want to think of PET, its major application today is in studying patients with cancer. The other area where we have a major role is in coronary artery disease, where agents like radioactive rubidium or N13 ammonia allow us to measure the blood flow to the heart, the blood flow through the coronary arteries, and to pick up patients who are candidates for heart attack with ischemia, or patients who are being considered for heart transplant or something of that nature. And we can measure the viability or the recoverability of the heart with glucose to measure its function. Now, here's what PET scanners look like today. There are three major ones on the market. Siemens, and CTI, which I guess many of you are familiar with because of its proximity, is a lithium silicate-based detector. And the picture of one shown here. The GE Tech detector is Bismuth germinate, and the one that we have at my institution is the Gemini, which is unique because it's sort of hump-shaped like a camel, and you can actually move these two pieces apart. Now, PET today has evolved from being a positron imaging modality to a combined modality where most of the patients that we study are being looked at both with CT and PET. Appreciate it from this picture here. This is actually a CT, computerized tomograph device. This is the PET. The patient will come into the machine, have a CT, and there are two kinds of CT they can have. They can have one which allows us to correct the PET image, and I'll explain that to you in a few minutes, or they can have a diagnostic CT, the kind you would have if your physician thought something was wrong and they wanted an X-ray to identify the anatomic problem. The table then moves down, and a PET is performed, and it's a sequence of acquisitions taking maybe 3 to 4 minutes apiece, and 7 to 8 acquisitions, so the whole body is imaged. PET is almost invariably a whole body image. And then the procedure is over. Now this differ very greatly in how they're done and what their principles are. But for the most part now, the kinds of machines you'll see and the machines that are being sold today are combined PET CT machines. These are just PET devices here. The GE one is one big PET CT, and the Biograph, the Siemens one, is also one large machine. But it's really two pieces, a CT and a PET. Here's a close-up of what it looks like with the patient. These tables slide, at this phase put, table slides through the machine. Here you see a patient, well, a pseudo-patient posing, and our tender-loving technologists. Now, these are the principles behind the devices. So PET, which I'm not going to talk about today, but I want to make you aware of, is single photon emission tomography. And this is a commonly used nuclear medicine device. Most nuclear medicine institutions have this. It consists generally of two detectors which rotate around the patient's body. And you see the arrow coming out of the patient, and this is from some radioactive tracer that's been injected into the patient, and we're detecting now the location and the amount of radioactivity. With PET, it's a dedicated ring of detectors, one of the compounds I mentioned before, and it's a positron emitting tracer, so you get simultaneous detection from opposite directions. I'll explain that again in a minute. And that differs greatly from CT, where you see in CT a source of radiation, an X-ray tube, is rotating around the patient, and you're detecting the transmission of the X-rays through the patient. So with the CT, you're just detecting how much X-ray gets through, what's the density of the patient. With the PET, you're detecting where the material you injected went, and thereby measuring how that particular organ that you're looking at is functioning. We use a lot of different tracers for a lot of different purposes. Rubidium-82 and gallium-68 are both generator produced. A generator means that you have a column that you can elute, and you get the radioactive material off of it. So something like rubidium, which has a 1-minute half-life, would be very hard to prepare commercially and then ship to wherever your PET facility is. But if you have a generator, you have a long-lived parent, and the rubidium is the daughter, which you then can use for whatever diagnostic test you plan. I mentioned earlier, that's used for measuring blood flow in the heart. It's also been used to look at kidney. Gallium-68 is mainly experimental now. F-18 is fluoride-18. That's the workhorse of PET in clinical medicine today, and we'll talk about that some more. The advantage of these three, carbon, nitrogen, and oxygen, is that these are the building blocks of normal proteins. Carbon, nitrogen, oxygen is what we're all made of. And the original impetus for developing PET was because the only radioactive isotopes that you could use for studying processes within the body were positron emitters. These are all three positron emitters. And they allowed you to synthesize the normal constituents of the body and see what was going on. But that's not practical clinically because these are very short-lived. 2 minutes, 10 minutes, and 20 minutes. I think half the activity is gone. Fluorine-18 is much better, 109 minutes, and so most of the work we do today is with fluorine. Yeah, I just remembered. Okay, so what is positron emission? Well, we live in a sea of electrons, and that's shown here. And then along comes a positron from the nucleus of the atom we're involved in, and it collides. And this is a matter, antimatter sort of occurrence. It's a science fiction thing. When the positron hits the electron, it's gone. And one of the products is two gamma rays of 511 keV. And the thing that makes PET possible is these are emitted in opposite directions. And not always exactly 180 degrees from each other, but close enough so that if an event occurs here in the detector, and occurs here in the detector, and it occurs at the same time, we know that it must have happened somewhere along this line. And that gives us a great resolving power and ability to determine where something occurred in the body. The detectors I mentioned are a circular array made of various substances, and they'll go around the whole crystal, and the patient goes into the bore here. And here you see a little more clearly what happens when we image a patient. This would be a patient. A positron comes out, annihilates here, it will originate in the body. You get your two gamma rays, these occur, and there's a coincidence circuit so that if these two events occur, one event here and one event here, within a very short time interval, and we're talking about nanoseconds, then it's decided that that is a real event, and the location of the original occurrence is plotted in the computer. Now, one of the problems, which is a physics engineering problem, is that it's possible for random events to occur. In other words, a gamma ray could originate here and here, hit the detector here and here, but if these two events occur at approximately the same time, then the computer thinks they occurred along this line. So that degrades our image, because we're going to think something happened here when, in fact, they're two unrelated events. What we want is this. So we have true coincidences, which make up about 90% or so of our images, and then random coincidences, which degrade it, and there are a lot of algorithms around to try to improve this, to improve our resolution of our images. Now, our problems besides that are attenuation correction, which refers to the fact that when the gamma ray is emitted within the body, it's absorbed to some extent. It's attenuated. We have to reconstruct the image, and that's where the random coincidences become a problem. And then anatomic correlation. When you'll see the images, which I'll show you in a few minutes, it may be difficult sometimes to know exactly where the object you're looking at is in the body. So if, say, you see a cancer, a tumor in some portion of the body, and the surgeon's going to operate on that patient, the surgeon wants to know, where should I look for this? And you can't say, well, it's somewhere in the chest, because he didn't need you in the first place. You have to give him a little better location. And that's how CT became a very popular component of PET, because with CT, we're able to achieve much better anatomic correlation. So we have a physiologic tool, the PET, and an anatomic correlative, the CT. Whoops. Now, the attenuation results from a lot of things. One is that as you go up the energy scale in this range of 500 keV, there's a lot of Compton effects, so you get scatter. That scatter, as I said, leads to the possibility of random coincidences. There's different absorption rates that we have to take into account when we look at the images. If the gamma ray just goes through water, this is the approximate percent transmitted. If it goes through bone, you see the absorption is much greater. If it goes through sodium iodide, which is a detector that's used in some machines, it's greater, and then, of course, lead absorbs almost all of the gamma rays. So because the body is composed of different densities, we're able to get CTs and evaluate the CTs, but that's a problem for us in PET because it causes attenuation of the emission. This just shows you the actual attenuation. You can see here, this is water attenuation, the curve. This is bone, and then different attenuation. So we have to be able to somehow correct for how much radioactivity is getting through the water and how much through the bone. And just to show you some numbers, here's water, here's bone, and PET has one set of attenuations, and now we're correcting that image with either a gamma emitter or with CT. But CT has entirely different attenuation corrections than PET. If you look at water, the attenuation correction is 0.09 per centimeter. But CT is much higher. CT is a much lower energy emission, so much more of it is absorbed. So if we make a CT map to correct our PET image, we have to bring it up to what would have been absorbed if it were a gamma, 511 keV. Now let me just now start to pull this together for you. This is a PET image here. These are lungs, okay, and these are what's called coronal sections, and what you're looking at as you're scrolling through the body. So you're moving through the body. Here's posteriorly, here's the heart. You see the heart outlined here. And what that is, that's the absorption of the gamma rays as it's transmitted through the heart. And that's with a cesium source. This is 662 keV, to create a transmission map. Okay. So what we do, we have a patient who has radioisotope in him. Out come the gamma rays, but some of them are absorbed by the organic materials. We then transmit through the patient using an external source, either X-ray or gamma rays, a transmission map to show what's absorbed. You see the lungs here very clearly because the lung is mostly air. There's very little absorption of the radioactivity. Here in the abdomen, there's a lot more. And that image is now used to create the image we finally use for the diagnostic evaluation. So we can do the attenuation correction with CT, or we can do it with CT. Now, the advantage of CT, the reason CT has become very popular, is the transmission map is less noisy. You get better definition of the anatomic structures than when you transmit just gamma rays through it. The scan time is very short, just a few seconds, and it reduces the photo imaging time. So CT's become very popular for the attenuation correction. But it has disadvantages. I showed you before, the CT has to be scaled down to the same energy as the gamma ray. Contrast or metallic implants, for instance, someone has an artificial hip. When you do a CT, you get all kinds of blurring, and it causes error. And then breathing leads to misregistration. I'll show you what I mean by that in a few minutes. The correction for the CT is done this way. CT is measured in Hounsfield's units, that's the density in CT, and then that's corrected for what it would have been in terms of absorption for a 511 keV gamma. So, here are the maps. This is a cesium-137 map. This is obtained by having a cesium source outside the patient and then detecting the transmission of the gamma ray. And as I said before, by the lung, it shows very little transmission, and then the heart it shows up here. So this is done in that manner. The CT is done by doing a low-dose CT. This is not a diagnostic CT. It's a CT, but with very low amperage, so that you don't quite get diagnostic information, but you get enough information to be able to reconstruct how much of the 511 keV was absorbed by the body. And you can see, though, even though this is not a diagnostic quality, how much more information you get in terms of the anatomy. You see the heart, you actually see some vessels from the heart here. You appreciate the pelvic bones here and the spine. So cesium's popular, useful in some ways, but because the CT gives you so much anatomic information, the movement to combining the CT with the PET has gone forward. And here's the diagnostic study. This is the PET study. And you can appreciate here, let me point out what you're looking at. That's an abnormality right there. This is the kidney. This is an abnormality in the lung. Okay? The urinary bladder would be around here. But you see very poor definition. This is the heart right here. Very poor definition with just the uncorrected image, because you're not able to compensate for the differential absorption of the 511 keV that's emitted from the positron annihilation. Now here it is corrected with cesium. Now look at what happens here with this lesion in the lung. Look how much more clear it is to see the lesion in the lung. It's now gotten sharper. And if you look with the PET, you have even better contrast, because you've taken out the blurring caused by surrounding tissues. But you have a problem still, because look where the bottom of the lung is. Here's the top of the lung, here's the bottom on the CT. Here is somewhere in here, it's hard to tell in the PET, but approximately here is the excursion of the lung, and then here's the cesium one. So what's happening is the patient is breathing as you're doing the study. When you do the PET study, it takes about 3 minutes per view. These are about 7 views here, put together to make a total body. So the patient's breathing up and down all this time, and what you're looking at is an average of the excursion of the lung. With the cesium attenuation correction, that's relatively slow also, so it tends to be the same as for the PET, but for the CT one, patient generally takes a deep breath, and the lung ends up being much bigger than it is on the PET. So we're trying to correct the PET and make it more accurate, but we're correcting it with something which introduces an inherent error. So we do the image fusion for the exact location of the lesion to be able to tell the surgeon or whoever it is exactly where it is, and to direct a biopsy if you're doing a needle biopsy, or very popular today and increasing in use is using this to determine what your treatment field would be for somebody who has cancer who's going to receive radiation therapy. And the fused image looks like this. You see up here the CT. Now this is the PET scan, but it's been corrected with a CT so the image can be easily appreciated. This is an abnormal lesion in the lung. This is the liver. This is the spleen. And here's another lesion in the groin. And then this is what's called a fused image, where the CT is placed here, the PET is placed on top of it, and now you can go and determine anatomically where in the lung that lesion is, within a small margin of error. And we can also depict the PET as a three-dimensional image. They do it much better on CSI Miami or CSI New York, but we can do it also. Now let me show you the movement. Here's one of our problems, and one of the problems that we need engineers like you to work on. We get the PET image, we get the correction, we correct for the absorption. We can do that pretty well, but the patient's breathing. So what is the correct location of the arrow came back here? Is that lesion here, or is it here? So you see that moving up and down. And what we do, we get an image one place in time, and it's prone to a certain error. This is a gated image. This is from an experimental procedure. It's actually on a Siemens machine, which is not available commercially. Now the image gating is far from perfected. None of the commercial companies have image gating available to us. Basically, what is done is some device is used to detect the patient's breathing. You get the respiratory cycle, series of images, and then depending on where you are in the respiratory cycle, that image goes into a specific location for storage for analysis later. Now here's what the importance of that is. Here's a non-gated lesion. Okay, it's 4.2 centimeters square. When you gate it, that is, allow for movement of that lesion because the patient's breathing, it's down to 2.7 centimeters. And the SUV, which is a measurement of how much activity is in the area, goes from 8.7 to 11. So if we could gate these studies properly, they'd be more accurate, but it's one of our major problems now, and a problem which is seeking a simplified solution. Now, the way we quantitate the lesions is with what's called the SUV. In addition to just looking at the lesion and measuring the size of it, we're also interested in how much uptake there is. For instance, say you have a patient who has a tumor that's being treated with radiation therapy or chemotherapy. You want to know, is that tumor responding to therapy? Well, if you follow the patient serially, what will happen is if they are responding, the amount of activity in the lesion will get less. If the tumor is growing, the activity will get more. And one of the ways we have of determining that is with the so-called standard uptake value. This is the tissue concentration of tracer divided by the expected activity divided by the whole weight. And it's malignant lesions have higher uptake than benign lesions, and it can assign a grade. Tumors which are more aggressive will tend to have higher SUVs, and as I said, to monitor therapy. This again is an imperfect measurement which could use some improvement. Again, we need engineers to help us fix this. There are partial volume effects. Partial volume refers to the fact that any kind of abnormal lesion is surrounded by some normal tissue. And the number we get is an average of the area we chose, how much normal tissue is included and how much abnormal. The size. The smaller the lesion, the harder it is to get the right number. The geometry. The lesions are not necessarily round. They have all kinds of different shapes, and so we're concerned about what is the correct number. And the region of interest is basically the line we draw around it to say, yes, we want to know what the SUV is in this particular area. So the PET diameter is another approach where we just measure the size of the lesion. But I showed you before that too is affected by respiration, but that can help us to get around some of the problems with SUV. So our two methods of looking at tumor and tumor progression are SUV and PET and diameter, but both suffer to some extent from the breathing artifact, or in the heart, the beating of the heart. Now, recent advances in SUV are we've discovered that the SUV increases in tumors with time. So if you measure the SUV twice, we can tell the difference between tumors and inflammation, which tend to be confused in some circumstances, but creates a certain problem because doing 2 PETs on a single patient in one day is very expensive. And then changes in SUV measurement over time, as I said, help us better to distinguish what's going on. In order to do the SUV, we have to calibrate the scanner. It measures basically millicuries per gram of tissue over the millicurie injected and divided by the patient's weight. So it's a standardized uptake measurement. When you compare SUV values, we have to keep in mind that they're done the same way. We should wait the same time and do it in a dynamic fashion. In my department, we used to have a rule. It's called Sugarman's Law. Sugarman's Law was if you had a study in a patient which was critically important to diagnose what was going on, and then that patient came back to evaluate what had transpired over the last 6 months, the patient would invariably be done on a different machine with a different technique, and there would be no way of knowing it. With PET, it's not such a problem because we don't have that many PET scanners. Now, this is sort of a very quick overview of what the PET machinery is about and how we approach it. Let me show you some of the traces we're talking about that we use to do PET and some of their characteristics. We have 2 types of approaches in PET. One is we look at molecular processes, and that's using traces which are aimed at some specific, very specific function within an organ with the body. And then we have a very general approach looking at glucose metabolism with F18 fluorodeoxyglucose. And that's the agent that we use most and which is the basis of most of our PET imaging. For the molecular traces, we can measure blood flow, O15, we can measure tissue oxygenation, protein transport, protein synthesis, cell proliferation. Each of these depends on a different tracer, many of which are not yet ready for clinical use because they're still C11 labeled. Some do have F18 labels or other kinds of labels that can allow us to buy it from a central facility and to use it. The shorter-lived isotopes have to be done in centers that have their own cyclotron and can produce it themselves. But F18 FDG is the basis of PET. And all the images I've shown you so far were done with F18 FDG. Now, why is it useful? Well, FDG behaves like glucose in its initial uptake. It's phosphorylated within the cell, but not further metabolized. And in general, tumor uptake of FDG is greater than normal tissue. So we're able to determine the presence or absence of malignant tissue because the FDG uptake is much higher than in the surrounding normal tissue. And also, in the heart, in myocardium that's not healthy, FDG uptake tends to be increased. Now, most tumors, more than many, most tumors have increased FDG compared to muscle or other tissue. And the reason for this is because the relatively reduced blood supply in a tumor changes it over to anaerobic metabolism, which depends on glucose. Now, F18, which is our mainstay, is produced in a cyclotron from O18. It's a proton-neutron reaction. The proton hits it, and you get F18 plus a neutron. The F18 is then incorporated into glucose, and the F18 decays, giving you the positron, which is the workhorse for us. So that's our main isotope. That's what we use on a daily clinical basis. And this is what F18 deoxyglucose looks like compared to glucose. Glucose only is substituted in one position. There's a hydroxyl removed and an F18 put in at the 5 position. And that's a very important change because in some ways it retains the same characteristics as glucose, but in other ways it doesn't. The FDG, when it's injected into the bloodstream, circulates just like glucose. It's transported across the cell membrane by the GLUT transporters, which are the molecular agents to move glucose into the cell. In the cell, hexokinase phosphorylates it and becomes fluorodeoxyglucose 6-phosphate. But then if it were glucose, it would go on to fructose 1, and it doesn't. Because once within the cell, although the transport into the cell is the same as glucose, once within the cell recognizes this is not glucose and doesn't go into the normal glucose cycle, and it stays in the cell for a long time. So that's the basis of our tumor imaging. The tumor takes up more FDG than normal tissue, so we get a lot in there. The FDG doesn't get metabolized, so it sits in the cell, so we see it. We have time to see its accumulation and to identify it, and we get hot spots like the lesion I showed you earlier when I showed you the picture. Normal tissues also take up FDG because glucose is normally metabolized. The brain, heart, kidney take up a lot. Now the kidney is interesting because of all the organs in the body, the kidney can tell the difference between FDG and glucose right up front. And so you get a lot of FDG in the urine, whereas normal kidneys absorb a lot of glucose. The liver, spleen, and GI tract also take up a small amount. So in interpreting these images, you have to have a very good understanding of what normal is and what abnormal is. Here's a normal PET scan in a normal patient. This is the CT. This is the PET. And the way we prefer to localize lesions rather than the fusion image, which I showed you earlier, is to put coordinates on the lesion to show, for instance, this area here corresponds to this area here. So we can localize it exactly. And here you see liver, kidneys, bladder, spleen, spine. And you can appreciate them better if you've seen pictures of normal anatomy. In the CT, you see it much more clearly. On the CT, you're just looking at relative tissue density. Here, you're looking at the kidney actually excreting the FDG, the liver and spleen taking up a small amount of it for metabolism, much like they would glucose. The heart shows up normally in many patients. This is the heart. This is FDG in the urine, again, in a normal patient. Muscles take up a lot of glucose. You can always tell if a patient's nervous just by looking at the scan. We inject the material and ask the patient to lie quietly for about 45 minutes so the glucose is taken up in the body, and then we can image it to see the abnormal lesion. Patients invariably will have uptake in the neck and in the various muscles throughout the body. This is the arm, the legs, and we ask the patient not to have any physical activity for at least 2 or 3 days before we do the scan, because more activity increases the uptake and makes it more difficult for us to interpret. And for instance, what's shown here is an extremely nervous patient. Patients get nervous, tense, they tense up the muscles in the neck. You see a lot of activity here, and that's actually in muscle. But the patient, if you give them Valium, they get relaxed, sometimes too much, and here you see the muscle uptake's gone. Here's a lesion that you never could have interpreted here because of the muscle activity. So when we look at patients, say, with head and neck lesions, we routinely give them a small amount of Valium to calm them down. Now, this varies tremendously from place to place. There are a lot of centers that don't ever use Valium. I guess living in the Bronx is traumatic, and we have to use it a lot. Now, let me just finish up, show you a couple of other areas that we do. This is what a heart study looks like on PET. We stress the patient. Now, because you're in a PET machine, you can't stress them on a treadmill or on a bicycle. They're stressed physiologically with an injection of some agent that causes the heart to work harder. So we do a resting study and a stress study. This whole study only takes about 10 minutes, and this is a normal heart. But you see here, this is the anterior ventricle here. Posterior, this is the septum of the heart. You can see right here a little bit. This is the right ventricle, which takes up much less activity than the left ventricle. And this is a perfectly normal study. Everything is symmetrical. All of the activity is where it should be. If a patient, say, had coronary artery disease, you would see some area where there would be a major reduction in activity. And this is very helpful for us, especially in patients who are big, because the big fat patients are hard to image on standard nuclear medicine equipment, so we use the PET for them because the 511 keV is more easily imaged. We also do brain work in patients, particularly refractory seizures. This is a patient with temporal lobe epilepsy. I think you can all appreciate that there's no activity over here. That's the temporal lobe, the left temporal lobe of the brain. By convention, we do this as if the patient is looking at us. In patients who have intractable seizures, you want to find some place where there's abnormal activity to consider whether or not a surgical intervention might do something to relieve those seizures. That person has something wrong in the temporal lobe. And we can present this in a rotating three-dimensional image, which is helpful. It helps you pick out some abnormal spots. It's the same patient. You can appreciate the convolutions in the brain, the gyri, and over here, as the patient comes around, you can see that there's no temporal lobe here. Swing around the other side, you can see the normal shape of the brain. And we can present any of the images in a three-dimensional form and rotating to help pick up abnormalities. All right, this is the last slide I'm going to show. And it's just because one of the questions that comes up invariably is how much radiation is involved. And the radiation dose actually with PET imaging is very small. Gallium citrate is an agent that we use in routine nuclear medicine in people who are suspected of having infection. And these are the radiation doses for the critical organs: bone, bladder, intestine, bone marrow. And this is technetium MDP used for bone scans. Patients who have problems with the bone, who have, say, orthopedic problems, who have question of infection in the bone, we use TEC-MDP. And F18-FDG, as I said, is the workhorse in PET. And you can see that if you look at these numbers, 0.24 for the bladder, 0.19 for MDP, 0.3 for gallium. So the radiation dose is right within standard medical practice and is very acceptable. So what is PET? PET is a very sensitive, high-resolution procedure that allows us to get images of the body in a wide variety of diseases that could not be approached otherwise. It's revolutionized in the last 5 years our approach to the diagnosis and treatment of cancer. It is not an anatomic imaging device, it's a metabolic imaging device. It lets us see what the body is doing. And we can image almost anything if we can make a tracer that will go to it. FDG mimics glucose, so we can see how the body's metabolizing glucose. We can label testosterone, we can label estradiol, and see where that goes. in relation to male disease problems or women with ovarian cancer. So as these agents become available, this field will grow tremendously. But even though it's growing, as I pointed out in the beginning, it's far from a perfect imaging technique. There are problems with respiratory movement. There are problems with absorption of the radioactivity within the body, so you don't quite get the right location, you don't quite get the right amount of activity, and there's lots of room for improvement. So just as we will develop new radiopharmaceuticals and be able to image more and more organs and more diseases in a wide variety of pathologic states, I hope in the next decade you guys will fix all the remaining engineering problems, and in 10 years we'll have a perfect device, and we may not cure human disease, but we'll make it a lot easier to diagnose it. Thank you.
Okay, we do have time for some questions and comments. I'll ask the first question. I asked this question at lunch, and so I know the answer, but I want to share it with you. How did the Albert Einstein College, how does its name come about? Give us the history of that.
Oh, okay. Well, not related to PET.
I love history.
Okay. Well, history of PET's interesting. There was no Jewish medical school, no medical school under Jewish auspices in the United States prior to 1950. And what happened then in New York City, a group of prominent Jewish business leaders got together and wanted to sponsor the founding of a school. And they recognized that any school, part of a school's success is, of course, how good its faculty is, how good its student body is. But another part is also name recognition. You hear the name of a college that's well known, you immediately think, oh, that's great, even though the guy may have graduated in the bottom of his class or her class. So they got the idea of asking Albert Einstein to allow us to use his name. One of the founding was a man named Helmut Nathan, who was a good friend of Einstein. They went to him, asked him for his permission. He agreed. He participated in the groundbreaking ceremonies, and we've been the Albert Einstein College of Medicine ever since. So we had immediate recognition.
Another question.
Yes.
Several years ago in the Wall Street Journal, I remember reading an interesting article saying that in Japan, they were starting to add to executives compensation package that they would get PET scans every so often. And I was wondering how you.
I think that's total and utter insanity. Let me explain something. In any diagnosis, any diagnostic technique, especially the imaging techniques where there's a lot of qualitative interpretation, I mean, don't get fooled into thinking because you have an X-ray and the radiologist says everything is okay that he's actually seen. There's an error involved because there's a cognitive function involved here. So there are false positives, false negatives, true positives, and true negatives with everything. If you take a disease where there's a high probability before the test that the patient has that disease, you do very, very well. But if you take a disease where there's a low probability and do a test, the false positives begin to become a problem. For instance, renovascular hypertension is hypertension caused by disease of the arteries supplying the kidney. If you take a general population, the chance of any individual having renovascular hypertension is only about 1%, maybe less, 1 to 2%. The test that's used to make the diagnosis has an 80% sensitivity and about a 10% false positive rate. Now that's okay if half or more of the patients are going to have the disease, but when most of them are not going to have the disease, you end up with an enormous number of false positives. So if you start sending normal people for a test like PET, which costs about $2,000 a shot, and they don't have disease, you're going to cause a lot of unhappy people because a lot of people are going to have something wrong on the PET which is not necessarily significant. They're going to have follow-up tests and all kinds of problems. When I was at the Mayo Clinic, they used to routinely do protein electrophoresis. That's where you take the serum proteins and you divide it up into the different components that it's made of. And every now and then somebody would come up with an abnormal protein electrophoresis. And most of the time, they would turn out not to have any disease. But then you'd spend an enormous amount of money tracking down this abnormal test. Most tests should be reserved for people who are likely to have the disease, except for those tests which are very non-invasive, very inexpensive, and very accurate. And we don't have that many things like that.
Okay, now, you had put up several isotopes and said that cyclotrons were used to generate ones. And so a hospital would have its own cyclotron?
There are, I can't tell you how many, there are a number of facilities throughout the United States where the way PET got started was only using cyclotron-produced isotopes, O15, carbon-11, and nitrogen. So it started out in facilities that were willing to invest the money to put in a cyclotron, and those are mainly research-dominated facilities. Then as it grew, it became more used. F-18 became available. Now, F-18 has a long half-life, 109 minutes, so it's not hard to make it a half hour, an hour away from the facility that's going to use it. As its utility in diagnosing cancer was demonstrated and became more widespread, commercial companies started putting in cyclotrons to make FDG to ship to the clinical testing unit. So now, in the United States, there are probably somewhere in the neighborhood of 3,000 or 4,000 PET facilities, and a large number of commercial facilities supplying their radioisotopes. In New York City, we buy our FDG from a company called Eastern Isotopes, which has a cyclotron in New Jersey. There are a couple of hospitals in New York that have their own cyclotrons. Sloan Kettering has had it for years based on a physics program they have. North Shore Hospital has a cyclotron. But most of the hospitals in the New York metropolitan area buy the FDG commercially.
Are the generators from U.S.-based companies, or are they coming in from?
The rubidium is from the rubidium generator it's a krypton rubidium generator. It's from a U.S. company. It's and I forgot which one. Good. Pardon? No, it's a pharmaceutical company. Well, the reason I forgot which one is because it used to be from Squid, but you know these guys, they buy each other out every 15 minutes, so I'm not sure who owns it now. But they're U.S.
Yeah, Martin?
It seems that two of the problems are resolution and intensity, which
Right.
translates into the problem of motion. Are these inherent limitations, or do you think that they could be very improved?
Okay. The inherent limitation on resolution is the path length of the positron, which for fluoride 18 is in the neighborhood of a millimeter. Okay, so inherently you couldn't get down. You can never get down to X-rays to tenths of a millimeter. But the resolution of the machines today, the best resolution there's one machine on the market has a resolution of 4.5 millimeters. But that's for a source in the center of the field, at the field. As you move out, the resolution degrades. It's hard to get around that because you have the body surrounding the emission site, and so you're getting some scatter. Small animal PETs, we use PET for small animal imaging too. We can image rats, mice even. And the small animal PETs have a bore only about 4 or 5 centimeters wide. So you get over this problem of distance from the center. And a small animal PET gets down to between 1 and 1.5 millimeters. So with a small animal PET, we're right there. The ones for people, though, are up about 4.5. So you got 2 or 3 millimeters that perhaps we could get better to. A few years ago, the resolution was 8 millimeters. It's changing rapidly. The detectors are improving. And then, of course, the motion is the other problem, but gating will help that. And gating will probably have gating in a couple of years.
Jeff?
You had mentioned that the CT using an external source for imaging.
Right.
What is CT with contrast?
A CT with contrast, if you just use an external source, you're depending on the inherent difference in density between the different organs in the body, okay? So it's easy with bone, bone sticks out. But say you start getting into lymph nodes versus vascular structures, they can look exactly the same on a CT. Contrast is some sort of iodinated medium, iodine being a high molecular weight, injected into, it's usually iodinated organic acid that's injected into the patient, and then it opacifies the blood vessels and allows us to differentiate vasculature from other organs. There are other kinds of contrast media. You have contrast media that's excreted by the kidney, makes the kidney stand out, and then there's oral contrast media where instead of injecting it intravenously, you take it by mouth. That allows you to see the intestinal tract because it makes the intestinal tract opaque. It's more dense, so you see where the tract is and you can differentiate it. The whole idea of contrast is to outline known normal structures like intestinal tract or the vasculature and allow you to differentiate from abnormal structures.
Ted?
How well is it affecting capacity of cancer? Because you said that the FDGs have mainly in the anaerobic side of the metabolism. What about if you have a cancer that's metastasized and you don't have...
Well, tumors almost universally anaerobic because they're growing very rapidly. They have an inadequate blood supply. And it was shown back in the 1930s, Warburg showed that tumors are based on anaerobic metabolism. The place where PET has its greatest use, one place is in lymphoma, which tends to have multiple sites. And then many of the indications I showed you at the beginning of the lecture are for recurrence. In other words, you wouldn't do a PET in a patient who has a primary colon cancer. But a patient who's suspected of having recurrent colon cancer, you would to determine where the metastases is. We do very well in detecting spread. Another problem that you probably wouldn't be aware of with the CT, if you see a lymph node, the decision of whether that lymph node is normal or abnormal is based on its size. Between 1 centimeter and 1.2 centimeters is considered normal. Above that, you start to be concerned about it being abnormal. But you can have spread of a cancer to a lymph node, and the lymph node may only be 0.7 millimeters in size. How do you know it's abnormal? Well, you give the fluorine deoxyglucose, and that'll take up enough FDG. And when you see a node that's metabolizing glucose abnormally, you know something's going on there.
Okay. I want to make one final comment regarding PET. We have a company locally that manufactures and markets PET equipment, including the cyclotrons. That's CTI, molecular imaging. And my real reason for mentioning that is that the founders of the company are graduates of the UT College of Engineering. Okay? So, with that final comment, let me invite everyone. As usual, we have today. Actually, we have many new faces in the audience. You may not know that we have a reception immediately following this presentation downstairs on the second floor, and everyone is invited. But before we adjourn, let's express our appreciation again to Dr. Blaufox. Can you take him down to all the students will follow?